Hello, and welcome back to the American Society for Stereotactic and Functional Neurosurgery podcast. If you haven't taken a listen to our first two episodes, check out our Twitter account and Buzzsprout to take a listen. And if you haven't followed us on Twitter, the ASSFN Twitter handle is ASSF Neurosurgery. I'm Danika, Paulo, Vanderbilt Neurosurgery resident, and I'm here with my podcast co-host, Dr. Robert Ziechmann.
So I'm a fourth-year neurosurgery resident at Temple University Hospital. I'd like to introduce our guest for today, Dr. Jason Schwalb, who is the Surgical Director of Movement Disorders and Epilepsy at Henry Ford Health System. Before we get started, I wanted to briefly introduce our topic, the ASSFN position statement on laser interstitial thermal therapy for the treatment of medically refractory epilepsy. For those of our listeners who are newer to the topic, epilepsy affects about 1% of the general population, and in about 1/3 of patients with epilepsy, seizures are not controlled with medication alone, what we refer to as medically refractory epilepsy. For medically refractory epilepsy, surgery may provide complete freedom from seizures in up to 70% of patients with temporal lobe epilepsy, when appropriately selected. And then for temporal lobe epilepsy, this has traditionally meant surgical resection or removal of about 4 to 6 centimeters of the anterior temporal lobe. In the past several years, laser interstitial thermal therapy or laser ablation has emerged as a minimally invasive means to achieve similar results by, instead of resecting this tissue, ablating it with heat energy. Dr. Schwalb, is there anything you would add?
No, I think that's right. I mean, I think listeners should know, whether they're neurosurgeons or non-neurosurgeons, that epilepsy surgery has been done for over 100 years. It's one of the most successful surgeries we do. Number needed to treat to get a positive life-changing effect is 2, which is better than almost every other surgery or medication known to man. Epilepsy tends to be sort of underplayed into how life-threatening and dangerous certain types of epilepsies can be. And so we know that epilepsy surgery is really underutilized in the United States. And so, frankly, one of the ways that we're hoping that this problem will be addressed is with less scary techniques like LITT that may be a better option or safer option, or at least perceived as safer by neurologists and patients.
Thank you for providing that perspective. Now, before we get too far into our topic, could you tell us a little bit about yourself, your clinical interests, and your research interests?
Yeah, so I'm a functional neurosurgeon, as you mentioned, at Henry Ford in Detroit metro area. I did my residency at the University of Pennsylvania and then did fellowship at the University of Toronto. And I've been on staff. I've been out of training for, I guess, 17 years, and I've been at Henry Ford about 12. I have a pretty broad functional practice. I think some people tend to focus in one area or the other, but my practice includes epilepsy, movement disorders, pain, facial pain, and I also I have a pretty significant practice in complex peripheral nerve and in adult hydrocephalus. So I tend to do the whole gamut. In terms of my research interests, we've tended to be early adopters and try to promulgate new technologies here. And a lot of my work has been around that in pivotal clinical trials, as well as with quality improvement and healthcare delivery.
So for our next question, Danika?
Yeah, so we were curious to know, why did the ASSFN decide to create a position statement on clinical issues such as MR-guided LITT for epilepsy?
Well, we started the process, frankly, just before the FDA gave approval for this technology for epilepsy. But to be honest, like, one of the main drivers was that we're hearing from our members, and we've been encountering problems with getting insurance approval for these techniques. Some of that is frankly our own fault, in that we need to have updated guidelines, and our most recent guidelines had stated that this was kind of a new and experimental therapy. And therefore, insurers were like, well, we're not going to pay for it if it's new and investigational. I think in general, our feeling was that this was no longer investigational. We had enough cases nationwide that we felt that it was safe and pretty comparable to selective amygdalohippocampectomy, and frankly, a lot safer than existing techniques for another lesion that can cause epilepsy called a hypothalamic hamartoma, where it's really become the standard of care. And I think, one way to think about it is that this is really just a tool. LITT, which is laser interstitial thermal therapy, for those who don't know, involves putting a laser probe into a structure that you want to ablate or burn. And the real change that made this really viable is that you can do this in an MRI scanner and look at the temperature of different pixels and voxels in real time. So you can put a laser fiber in, bring the patient to MRI, run laser energy through it, and get a very discrete ablation of an epileptogenic focus while monitoring it in real time to make sure that the temperature isn't going too high in other structures that you don't want to damage, and making sure that you have enough damage in those areas that you want to damage. And I think for many of us, this has really just become a tool now that the safety has kind of been borne out. And, we really didn't need prospective trials to say that we could use a Cavitron ultrasonic device, CUSA or something like that, to take out a brain tumor or take out a temporal lobe, rather than using just gentle suction, because it's not that different, because it's just a technology, it's another tool in our hands. It's not necessarily really changing how we think about epilepsy. It's just another tool in our arsenal.
Right, absolutely, and a tool that it's important to spread word about and have some guidelines to how to apply it. So that makes sense. Thank you.
So I was wondering, what literature did you use to make the recommendations, and what was the process like in putting them together?
Yeah, I think a lot of it was really looking at case series. We don't have a randomized controlled trial. There has been a trial ongoing that actually I'm, one of the participants in, that is sponsored by Medtronic for laser ablation for mesial temporal lobe epilepsy. And frankly, the recruitment for that has been very slow because there really is no clinical equipoise at this point. And I think that was really a large part of our feeling why we needed this position statement. So it's hard, you can't do a randomized control trial and say, okay, we've got 20 people, we're on this airplane, we're going to give 10 of you parachutes and throw all 20 of you out of the plane, and we'll see who does well and who lands safely. No one's going to risk being randomized to the group without parachutes. And I think at this point, for something like laser ablation, patients just really don't want to be randomized to laser ablation versus a big open surgery. Even though big open surgery is very safe and very effective, that's just not where people's heads are at. And so, even the trial that we were participating in had a lot of trouble recruiting, because people could just get services outside the trial with most insurance payers, but we're having trouble with others. So that's part of the issue.
And what are the main points of this position statement that you want providers or even patients who are reading this to really take away?
Well, I think we started by really reiterating who should be considered for epilepsy surgery. And I think that's probably the most appropriate. In general, patients who have failed 2 appropriately chosen medications at appropriate doses with localization-related epilepsy, they're not going to be cured by some new medication. There is one new medication that's just come out that, a lot of our neurology colleagues are very excited about. But I think in general, we might see at most a 15% seizure-free rate or significant seizure reduction. But in general, if you've failed two appropriately chosen meds, your likelihood of becoming seizure-free on a new medication or combination of medications is only 4%. And that hasn't changed in 20 years, even with most of the new meds. So this new medication may be slightly better than that, but probably not hugely better than that. And conversely, as I said, bad epilepsy is dangerous. So if you have 3 grand mal seizures a year, your likelihood of dying in the next decade is about 25%. Let alone all the problems that you are going to have from having significant seizures and the morbidity, separate from the mortality. So I think that's part of the important part of the statement. For this type of procedure, we're talking about an area that can be safely resected or removed. Is really what we're looking at. It's not functional cortex or functional part of the brain where if you ablate it, you're going to make your patient no longer cognitively the same person or leave them with significant neurologic deficits. So that's important. You have to really define where the seizures are coming from for this to work, same as you do for resective surgery. And then a lot of the other restrictions are pretty similar. We really do this in the MRI suite, so you have to be able to have an MRI. And just like with other surgeries we do, you have to be able to undergo anesthesia. You can't be on significant blood thinners that can't be held. But in general, our recommendations are really based on the experiences of many groups looking at these and then comparing them to data with open surgical procedures. And many of us have found that this is a really good option. It's much shorter length of stay. Frankly, the patients tend to tolerate it better. They almost invariably go home the next day. And frankly, for some deep-seated lesions where there's morbidity trying to get there through an open surgical approach, this is probably better in that you're not having to go through as much normal tissue to be able to get rid of that part of the brain that's causing seizures.
So one question I had was, is there anything that the statement doesn't cover or address particularly? Would that be covered in the future? And how would you see the position statement change as new trial results come out or case series come out?
Yeah, I mean, I think based on the literature, my view is that things are pretty similar between laser ablation and open resection, as long as you've really defined where the seizures are coming from. So I think that's pretty clear. There may be some potential benefits from this approach by not going through as much normal tissue. So there might be some benefits neuropsychologically that might be borne out with more evidence. And frankly, more data is better in terms of figuring out safety profiles and best practices. We published a paper as part of a multi-center group trying to define what area do you really need to ablate to get the best results, looking at post-operative MRIs across a number of different centers. And that was about 250 patients. So I think those sorts of things are going to be helpful as well. And then I think, most of this work has really been done in terms of mesial temporal lobe epilepsy and hypothalamic hamartomas. I think the really big areas of kind of we're starting to see use that will become more important as we get more data or things like tuberous sclerosis lesions in children, periventricular heterotopias, and other disorders of neuronal migration that cause epilepsy that might be amenable to this and might frankly be preferable for an approach using LITT as opposed to an open approach. But we'll have to see.
Right, absolutely. So how do you see this position statement impacting patient care, and how do you apply it when you're evaluating an epilepsy patient for surgery?
I can't say that it's really changed my approach so much, when I'm talking to a patient. I mean, I've tended to talk to patients about this as an option. We've been doing it for a long time at our center. I think what's making a difference, and we've already seen some changes in terms of insurance coverage policies, and that just makes it easier and gives patients more choice.
Right, absolutely. And if any of our listeners want to read the ASSFN statement, it is available on the ASSFN website. Thank you very much, Dr. Schwalb, for sharing your insights with us. Was there anything else that you wanted to share with our listeners?
No, I don't think so. I mean, I think for neurosurgical trainees, this is a really exciting field, that there's a lot of need for people who are good and want to learn how to do these techniques and be able to offer them to their patients. I think for patients, I think it's really important to understand just how bad epilepsy can be, and understand that there is hope for good outcomes. We have so many more technologies now than when I was in training, where it was really only open resection and vagus nerve stimulation. So now we've got all these different techniques, including LITT and responsive neurostimulation and deep brain stimulation, where we can really help people at very low risk. And frankly, even the way we investigate patients to figure out where their seizures are coming from is so much better, safer, and more easily tolerated than when I was in training, which frankly is not that long ago.
And I'm excited to see where it'll go in my time as an attending as well.
Yeah,
absolutely.
Yes, thank you so much.
Okay, take care.
Bye.
Thanks again to Dr. Schwalb. Thank you for joining us, and we look forward to the next episode in a few weeks. And to our listeners, we'd love to hear from you on social media about topics you would want to hear or questions you have about the podcast. We'll see you soon.